I would like to welcome you all to the Endometriosis Conundrum lecture series, wherein we'll have in-depth lectures on particular aspect of endometriosis. Endometriosis, as we all know, is a very perplexing disease, and then there are lots of changes constantly taking place in this particular aspect. There is a paradigm shift in endometriosis, and we are also moving away from relying only on surgical confirmation for diagnosis to incorporating also the clinical assessment, imaging, and even also the potential biomarkers. So now this shift aims to mainly expedite the diagnosis, and also we have to give them personalized treatment and thereby improving the patient outcome. So as we all know, it is a systemic and an inflammatory disease rather than solely focusing only on the particular point of endometriosis. So we need to treat the women in toto. So there are lots of studies on the non-invasive diagnosis of diagnostic markers of endometriosis, and also we have endometrial biomarkers and also the blood markers. But still, even now, we do not have categorically, we are not able to tell that this is the best biomarker for us to diagnose endometriosis and also to assess the prognosis of this particular disease. To highlight more on this particular aspect of this disease, we have organized this particular lecture series by our eminent Dr. Ramani Devi Madam. And just to highlight on the particular aspect of diagnosis, the management of endometriosis. So to start with, I would like to welcome Dr. Meena to say the Oxic prayer and take it forward. Yeah.
Okay, Madam, I request Sampath Kumari ma'am, President Madam Oxy, to welcome the audience for our first CME ma'am webinar.
1 minute, I'll join. Yes. Good evening to all. So this is for Oxy, we have more than 11 committees, and one of the committees are endometriosis committee, and the chair being Dr. Mala Raj. Now she will be doing this series every month. For this, we have almost, if it is an endometriosis, everyone knew that Ramani Madam is the appropriate person to be there to talk on endometriosis. Now we will start with the Oxy prayer, and then you go with the scientific session of Aetiopathogenic diagnosis and management by Dr. Ramani Deva. I wish all the success for Lamala to continue this endometriosis series. Next, Meena, you can tell the Oxy prayer.
Yes, ma'am. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Over to you, Mala ma'am, to introduce our guest speaker for the day.
So can I have the next slide, please? So as you all know, Ramani Devi, can I see the presentation of CV of Ramani Devi Madam?
Yes, Mala.
Yeah. So I don't know why I'm not able to see. 1 minute.
Mala, don't bother. You just make it short.
No, madam. Is the CV there?
Yeah, we can see.
Oh, yes, ma'am. We can see the CV, ma'am.
Yeah.
Shall I introduce, ma'am?
No, I will introduce her.
Okay.
So Ramani Devi Madam, as we all know, is in fact the encyclopedia of endometriosis. She was heading the endometriosis committee for Roxy, the chairperson. So she has got phenomenal knowledge and also experience in this particular specialty. So that is the reason she is our the first speaker for this entire series. So Madam was the past president of TNFOG 2024 and also the national vice president of Foxy 2020. She was also an international advisory board member of the Fertility Society of Bangladesh and ICOG Governing Council member 2018 to 20. So also the managing director of Ramakrishna Medical Center in Trichy and Janani Fertility Center. Of course, endometriosis chairperson to 2014 to 16, and also patron of IFS Tamil Nadu chapter and TNFOG, executive committee member of Endometriosis Society of India, and editor of Oxy GCPR on endometriosis 2017, peer reviewer of JOGI, ARJ, GO, and JAM. So she has got various awards and accolades, which is really running over pages. And also she has won almost 10 gold medals in UG and PG. She has almost 3 books, authored 3 books, and has more than 40 topics for the books and more than 42 scientific papers in her name. And she's also the editor of Endometriosis Update, published by the Endometriosis Society of India. So let us hear more from the current concept in the diagnosis, the investigations, and also the management of endometriosis from Ramni Devi, madam. Over to you,
Thank
madam.
you, Mala, for your kind introduction. Yeah, I will now share my screen. Good evening, everybody. Respected Madam Sampath Kumari, who is currently the president of Oxy, as well as the founder secretary of TNFOG, Dr. Meena Mahalingam, secretary for Oxy, and Dr. Mala Raj, and all the participants. My wishes to all of you, especially Dr. Mala Raj in her future ventures. So the topic given to me is paradigm shift in etiopathogenesis, diagnosis and management of endometriosis. To say endometriosis has got 2 main components. One is pain and infertility. So this is a picture I'm very fond. It is one of the paintings in Italy. See that this is a 17th century painting. You can see these 2 girls with a face blushed. And then you can see in the hip chain that is made up of thorns and apples, which are symbol of fertility, and acorns, they take a long time to grow. So that means in this picture, the painter has tried to say that this is a disease which causes severe cramping pain and fertility is hampered or delayed. So the 2 main components. Now, endometriosis, to say that it has been diagnosed persons with endometriosis. Like in the 17th century itself, they have known that many of the patients, they suffer from pain during menstruation. And there were so many treatments for that, or treatments. But only after the last century, in the 19th century, probably, we are able to get an overview of what is endometriosis. So everybody knows it's the presence of a normal endometrial tissue that is abnormally located other than the uterine cavity, and 10% of the women of reproductive age group, they suffer from endometriosis. The implant grows because of the increased MMP, and they invade the tissue in their vicinity, causing inflammatory reaction. So endometriosis still remains a mysterious disease as regards to its etiology, pathogenesis, diagnosis, and treatment, and it still remains to be a hot topic. So once when we were doing post-graduation, endometriosis is just given as a single topic, but we know endometriosis itself can be written as entirely as a whole book. And it is something like a blind man and the elephant. See how our limited knowledge leads to us to believe that it should be the whole truth. It is not truly so. See, that is why I thought I will give a lecture on this. So when you look into the PubMed publication, when you search, the number of publications on endometriosis and clinical trials are increasing day by day. And by 2024, most of the majority of the clinical trials that have been registered are on endometriosis. So this, everybody knows that 1 in 10 women of reproductive age group, they have endometriosis, and 30 to 50% of women with endometriosis are infertile. 25 to 35% of infertile women have endometriosis. And the prevalence in India worldwide, according to WHO, more than 260 million women suffer. And India, as per the Endometriosis Society India data, in 2007, Dr. P.D. Mahapatra said that it was 26 million women, they suffered, but now we know it is beyond 50 million women in India alone suffer from endometriosis, and even 5% of the girls below 18 who complains of dysmenorrhea are affected by endometriosis. So why this is a changing paradigm? See, previously we thought the deep-rooted thinking in yesteryears was, we thought it is just a gynecological lesion, and that was probably because of the paucity of the data, and diagnosis we need to confirm only by laparoscopy, and laparoscopy was a major issue in those years, and medical management, they thought it was only secondary, and removal of the lesion is the priority, and they did not know what is causing endometriosis and how recurrence means incomplete surgery was the thought that was existing previously. But we know that there are so many other reasons why recurrence occurs, and conception is mainly through ART that wasn't safe or that was primitive in those days, and no effect upon the ovary, it was thought. But we know that now the concept has changed. We thought it was a local disease involving only the genital system. But now the current thinking is it is no more a gynecological lesion, it is an inflammatory syndrome, because we have lot of richness of data is there, and there is no need for histological diagnosis. Once what we thought laparoscopy is the need of the hour to diagnose, we now just rely upon the clinical symptoms, and the medical management is supposed to be the primary, and preservation of ovarian reserve is a priority, and recurrence means it is not the incomplete surgery, but it is the persistent offending factor that is causing the recurrence. And now we know that ART is very safer and more effective, and conceptions can have occur through that. And endometriosis, that is what is called as nemesis of the eggs. The endometriosis per se can kill the ovarian reserve, and it is again now it is thought to be a systemic disease, systemic inflammatory disease. That means a person with endometriosis and adenomyosis are likely to experience chronic disease like cardiovascular disease and cerebrovascular disease are more common. It is supposed to affect the entire pathology because it's basically the inflammation. That same inflammation is being reflected upon all the systemic disorders. So there is a change in the etiopathogenesis, and American Society for Reproductive Medicine says that it should be viewed as a chronic inflammatory disease. So it requires a lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedure. So the treatment aims in elevating the pain, promoting fertility, reduce the recurrence, and improve the quality of the life of the patient. So the etiology becomes a very complex one, multifactorial, and it is still found to be a disease of theories. So the initial theories, what we thought was it was probably because of the retrograde menstruation, where there is the endometrial tissue sheds into the peritoneal cavity, and that gets attached to the peritoneum and becomes endometriosis. And then coelomic metaplasia theory, and then lymphovascular metastasis. That is the reason why we get endometriosis in the non-genital areas, and stem cells are coming into vogue of late, and hormonal reasons. So if you see this picture, you will understand that not only a simple retrograde or a coelomic metaplasia theory is causing, but there are a lot of things, newer concepts, that is the genomic alteration, epigenetic theory, that is DNA hypermethylation and histone modification, and more than that, this microRNA dysregulation are going to cause endometriosis. So all these things have appeared within the last 10 to 15 years. Again, this is how the invagination of the theory, where the cells invaginate into the myometrium, and then it can invaginate. This is for causing this adenomyosis, but in endometriosis, it invaginates the surface, and then lymphovascular dissemination, as I said, it leads to the extrapelvic lesions and stem cell theory. This also explains why you get endometriosis in odd places apart from genital areas. So this is again another important slide where it shows why infertility occurs in endometriosis. So we thought earlier the infertility in endometriosis was probably because of the huge endometriomas obstructing and causing the disturbances of the anatomical reason, but we know now that even early endometriotic spots can have some inflammatory changes and some immunological changes which are going to cause infertility. So to say a few, see, these are some of these endometriotic spots. And whenever there is endometriosis, what happens? Whenever there is a spill of the endometriotic tissue into the peritoneal cavity, it is the role of the macrophages to absorb them and then clear it out. But here, in women who are prone genetically for endometriosis, these macrophages get activated in an aberrant way, and this will lead to the release of so many inflammatory processes, cytokines, interleukins, tumor necrosis alpha, prostaglandins, neural growth factors, and then MC, matrix metalloproteinases, and all those things, IGF, all those things are elevated. And again, we must understand that each endometriotic tissue will behave as a apocrine gland, which is capable of producing its own estrogen level. That is because of the elevated aromatase level. Again, more than that, there is angiogenesis, neuroangiogenesis, steroidogenesis, that is more in favor of estrogen, and proliferation, invasion, and survival of all these things. So the proliferation of this neuroangiogenesis leads to severe pain. And again, whenever there is endometrioma of the ovary, what happens is this will cause nemesis of the eggs. That means the eggs are suppressed, the granulosa cell is reduced in volume, the number of quality of the oocytes becomes poor, and there is unruptured corpus luteum, and there is alteration of the tubo-ovarian relationship, and even the sperms, what happens to the sperms is because of the pro-inflammatory status of the peritoneal cavity, their functionality of the sperms gets depressed, and there is poor fertilization. Even if the sperms fertilize the oocyte, there may be, they have found out in the ART cycles that day 3, the development of the embryo to convert itself into blastocyst is being reduced. That means there is embryo, at the day 3 level itself, there is arrest of these embryos, and even if the embryos are formed, it can lead to ectopic pregnancy, which is of higher degree, and then it can cause implantation failure. Miscarriage rate is very high, and these are all because of the increased progesterone resistance. Basically, at the hormonal level, you have the hyperestrogenism and the progesterone resistance. Apart from this, there is activation of the C3 complement at the endometrial level. There is alteration of the HOXA10 gene, which is essential for implantation. FOXA11 is also aberrantly altered, that is needed for proper deserialization, and there is free radicals are increased. Glutathione peroxidase is also increased, and there is beta V3 integrin level is also suppressed. All those things will lead to poor implantation. So to summarize, the pathogenesis is different theories. Ultimately, they will culminate into increased estrogen level, prostaglandin production. Whenever there is increased estrogen, there is prostaglandin production, progesterone resistance. So what happens? Why there is increased estradiol? That we have to understand. There is genetic deficiency of 17-alpha-hydroxyprogesterone estrogen dehydrogenase, which will convert estradiol. In general, it will convert the E2 into the E1, and that is being taken off. But here, in patients with endometriosis, there is deficiency of the enzyme that converts E2 into E1, and hence there is piling up of the estradiol, which will cause a pro-inflammatory condition, and there is increased prostaglandin, and this will lead to increased pain. So ultimately, you get endometriosis. Again, we'll get a lot of challenges in diagnosing endometriosis. Previously, it was thought that it will take around 4 to 11 years for the diagnosis of the endometriosis to be correct, and there were no biomarkers or no specific features to define endometriosis. And again, the symptoms of endometriosis are not a single, it is always a non-specific symptom. A group of symptoms can happen, and no specific biomarkers are available, and there is lack of awareness both for the patients as well as for the general practitioners. And again, that will lead to delay, and often these patients will be seeing more than 6 or 7 consultants before a diagnosis is arrived. So that is a delay from symptom to diagnosis, normalization of the symptom and misdiagnosis, and still we have the 11 to 13% of the patients may be asymptomatic. So, but now we know that this diagnosis time to delay can be shortened. by the awareness that the consultants have got more towards endometriosis, as well as we are not dependent upon the imaging evidence or the histopathological, but only the symptoms are enough to treat the patient. So ESHRE guidelines in 2022 says that laparoscopy is no longer a gold standard. Previously, we used to say that laparoscopy is the gold standard in diagnosis and management. Again, NICE guidelines says empirical therapy prior to laparoscopy is the diagnostic and treatment algorithm unless fertility is the priority. So put it in a nutshell, all the pro-inflammatory factors like COX-2, prostaglandin E2, VEGF, MMP, interleukins, and TH1 cytokines, they are all upregulated. There is anti-apoptotic BCL2 gene, and then aromatase activity are upregulated, and the anti-inflammatory factors are downregulated. Ultimately, this leads to an estrogen-dependent, progesterone-resistant inflammatory disorder. Now, there is different behavior of the disease. The disease is not a single phenotype, and you have very different phenotypes. It can be a very early peritoneal lesion, it can be a ovarian endometrioma, it can be a deep infiltrative lesion, and adenomyosis, which is otherwise called as an endometriosis interna. See, here in each type of phenotype, the symptoms vary, and the patient with early peritoneal and endometriosis have got severe pain and symptoms, endometriosis associated pelvic pain, that is because of the increased levels of inflammatory region. But whereas in ovarian endometriomas, you can have huge endometrioma, ovarian endometrioma also without any symptoms, but it can cause infertility. And again, deep infiltrative endometriosis has got a different etiology, etiopathogenesis than that of the peritoneal and the ovarian, that can lead to very severe symptoms, very severe pain, because it causes nodules in the rectovaginal septum, as well as it can involve the bladder and some ureter, etc. So they are more symptomatic. They can produce dysmenorrhea, dyspareunia, severe dyspareunia. All these things can happen. Sorry. Diverse locations of the lesion. So not only in the pelvic cavity, but any organ in the body except the spleen can have extragenital endometriosis. So now there is a shift in the diagnosis, and that how to diagnose, we no longer depend upon the laparoscopy, but right from the history, clinical examination, imaging modality. Again, I tell you, all the imaging modality are not confirmatory, because early endometriosis, that is especially the peritoneal endometriosis, you may not have the imaging modality, and now biomarkers are coming into vogue. Previously, it has been mentioned even in 2022 ESHRE guideline that biomarkers should be only in the research setting, but I am sure that in days to come that biomarkers will be a part. Like previously, what we thought CA125 was a marker for to rule out malignant ovarian mass. Here again, we will have biomarkers. Then again, trial of treatment is going to be the modality in diagnosis, and no place for laparoscopy. And considering the symptoms, what is called as an endometriosis associated pelvic pain symptom, I'm very fond of the 70s: dysmenorrhea, dyspareunia, dysuria, dysphagia, dysfunctional uterine bleeding, diffuse abdominal pain, difficulty in conception. Ultimately, all of this will lead to depression and fatigability. In yesteryears, they were not aware that depression and fatigability can happen because of severe endometriosis. So now there is a shift in the diagnosis. One is trial of treatment. Either we can use combined oral contraceptive pills, or GnRH analogs, or progestins can be used as a trial. If they respond to this, maybe the patient is probably suffering from endometriosis, and no laparoscopy is currently needed. Now, according to Professor Chaperon, how to optimize the diagnosis? There is a necessary to change the paradigm. In 2019, there was no place for laparoscopy when endometriosis was clinically suspected, not even diagnosed. It is whenever it is clinically suspected, probably it is the right time at which we have to start the patient on treatment. So the olden algorithm was, we go by the medical history, physical examination, and of course we were having only the serological marker 125. No more it is indicated in diagnosis, but only for follow-up of endometriosis it can be used. And again, transvaginal sonography, and if you are not going to get anything by that, maybe MRI can help us. And then, so all these symptoms can have a presumptive diagnosis, and then these patients are subjected for the imaging. And in the MR imaging, apart from this, we can have a double contrast barium enema, multi-slice CT, cystoscopy, transrectal ultrasonography. They are all varying modalities to diagnose pelvic and extrapelvic endometriosis. And ultimately, laparoscopy and biopsy was thought to be the definitive diagnosis. But according to Eva Brosens, he says that even in 1997, non-invasive techniques such as color Doppler ultrasonography, particularly MRI, seems to be suitable for diagnosis and follow-up of the endometriosis. So ultrasonogram is found to be the key tool in diagnosis. Associate Professor Luc Rumbatus from Monash University, he says that there is a key paradigm shift in management of women with endometriosis, is that we know we have specialists who can diagnose endometriosis on ultrasound. So ultrasound almost, it gives us a pre-operative map of chocolate cyst or endometrioma, but also deep infiltrative endometriosis. So imaging can be by ultrasound, MRI or CT scan. CT scan is used mainly in extragenital endometriosis like scar endometriosis or urogenital endometriosis. So this is a very important ultrasound systematic approach to sonographic evaluation of pelvis in women with suspected endometriosis, that is called as International Deep Endometriosis Analysis Group, IDEA group. So these group of people are from Australia, Monash University, where they have given 4 basic sonographic steps to identify. So that means ultrasound, even in a very, very early lesion, you can pick it up. Routine evaluation, you have to do preliminary uterus adnexia, present sonographic signs of adenomyosis. And now we have, according to the Musa criteria, we have so many points to diagnose that adenomyosis by ultrasonography. Even if few of the markers are found, then we can come to a diagnosis. And again, evaluation of the transcervical sonographic soft markers, mainly that is the second step, where there is site-specific tenderness. When you put in the probe, the patient has wings with a pain, and the ovarian mobility is restricted, and there is the immobility of the rectal mucosa we can identify, and there is irregularity of the rectal mucosa. Assessment of the state of pouch of Douglas using real-time ultrasound based on sliding sign is absent in DIE, and as well as in uterus, in ovaries, both of the ovaries, if they have endometrioma, it is fixed to the pouch of Douglas and the sliding sign is absent. And assessment of dye nodules in anterior and posterior compartment is the 4th step. They probably say it will take around 1 year to diagnose, to get trained yourself in imaging using FR diagnosis of endometriosis. So this is the systematic diagram to show the sliding sign. It will be usually retroverted, fixed, and then when you put in the probe, the movement is restricted. But whereas in a normal one, this can be a sliding sign is elicited positive. Here, there are again schematic diagrams to show the presence of deep infiltrative. If you watch carefully, the space between the posterior uterine wall and the rectum gets narrowed, and the rectum, this you can have the involvement of the lesion here. And the second one is it causes narrowing, and then you can have infiltration into the muscular layer, and it is called as the moose antler, that is the Indian headdress sign or the moose antler sign. All those things can be elicited when you do a proper transrectal or a transvaginal ultrasonogram. So this is again anterior compartment. You can have bladder base, you can have endometriosis, or in the bladder dome, or it can involve the ureter, and sometimes the silent absence of kidney function is found to be the first thing in diagnosis of ureteral endometriosis. Or again, as I mentioned earlier, it can involve the rectovaginal septum, not encroaching the rectum or the vagina, or it can involve both the vagina and the rectum, and the entire rectovaginal septum can be involved. So there can be again an uterosacral involvement, and in the midline there can be opposition. The pouch of Douglas can be totally obliterated. So all these things, if you go by step, anterior, middle compartment, posterior compartment in the for 4 steps, then we will be able to pick up. So this was one of the papers that was published in 2020, where I was a part of this. the clinical diagnosis and early medical management of endometriosis. It was from a consensus from an Asian group where ultimately we came to a conclusion that medical treatment is recommended to reduce endometriosis associated pelvic pain for patients who have no immediate desire for pregnancy. So that means there is no need for surgery if the patient is suffering from pain. It is only the medical management. Even for women who want to have pregnancy, you can skip normal conception and go for ART in these cases. So I had with me Dr. Pratap Kumar and one more person from Kolkata, Dr. Siddharth Chatterjee. All three of us were from India, and Professor Thomas Romer and Tal Chaplin were heading the team. So according to Foxy 2024, in suspected endometriosis, the diagnostic steps, laparoscopy and imaging can be combined with the empirical treatment, hormonal contraceptive and progestins. That is the GDG statement. And in Foxy also agrees that women with clinical features suggestive of endometriosis, but even with negative imaging, empirical medical management should be offered before invasive modalities. So whether to treat the patient with the histology or without histology. Earlier, we were very sure that we have to put in a scope, get a tissue, get the biopsy, then only start treating. But now all the learned societies like ASHTE, SOGC, Foxy, World Endometriosis Society, ASRM, they are all for starting the treatment without histological confirmation. So now let us come to biomarkers. There are myriads of biomarkers which are available. First, let us know what are biomarkers. Biomarkers are nothing but they are circulating. It can be either a cytokine or a hormone or a cell immunological one or a microRNAs or a growth factors or glycoproteins which are found in the circulating blood and they are specific for certain disorders. So the idea of getting them is whether if they are positive, probably the disease is found to have disease is found to be positive. So let us come to endometriosis. I have already mentioned that there is inflammatory disease, hence interleukin 6, 8, tumor necrosis alpha, highly sensitive CRP, cancer antigens 125, CA 199, neutrophil lymphocyte ratio, HE4 that helps in differentiating endometrioma from malignancy. And the final one is the microRNA, which I am interested. So again, there are a lot of predictive biomarkers like proteomics and genomics are trying to help us, and even the specific proteomic changes that can be reflected in the saliva that can be picked up. And again, there is a genetic marker that can help in the diagnosis of endometriosis. So now my interest is microRNA as a non-invasive diagnostic marker. So this is nothing done. Non-invasive diagnostic testing is a medical procedure which does not penetrate or break the skin, mucosa or the body cavity, and it does not require any invasive incision. Non-invasive thing is certain advantages like there is no minimal to no pain or discomfort, no hospital stay, minimal recovery, downtime, no incision, stitches or scar. And this microRNAs can be picked up from the blood and serum, saliva, urine. And of course, for the peritoneal fluid, we need to have an invasive one. So simple thing, from the peripheral blood, we can pick them up. So these are all the diagnostic source of sample can be blood, tissue, stools. Even stools can identify, and vagina and the cervical scan. See, this is how the stool identifies is by the altered microbiome of the endometriosis. So each disease has got a specific microbiome. Like PCOS, it has got one group of microbiome, and stools have got a different one in endometriosis. So that can be picked up. And other things are the glycoproteins like CA 125, 1919, angiogenic factors, oxidative stress markers, inflammatory markers, cytokines, and hormone-related factors, microRNAs. These are all going to be very, very important. So this was one paper that was published in 2016 in Fertility Sterility Journal, which made me take up this particular testing for diagnosis. So here they have found out that it was by Hugh Taylor, who has done a lot of work both in endometriosis as well as in fibroids, and he was the person who was behind Elagolix trials. So he has chosen some of the microRNAs circulating in the body, and he has found out that 125, 150, 342 and 3613. These were all more specific. And here you can see all these microRNAs. 125 is very specific, that is highly upregulated, and MIR 3613 is highly downregulated. Apart from this, there is one more microRNA called as LET7B, which is extremely downregulated. So based on this mRNA, I tried my work, and this was the initial course study where he pulled that and where he took an number 24 numbers with the known endometriosis versus control group. And in the pooled microarray, he was able to get the result that this is the one, that is dysregulation of this miRNAs. So same thing I tried replicating in our own population. My initial study was involving 25 patients of control group proven by laparoscopy and 25 patients who had proven endometriosis by laparoscopy. So compared with no endometriosis by laparoscopy, proven endometriosis by laparoscopy, and we have done the same study. And this was again presented in FIGO, where this in this study we have actually incorporated 83 cases of endometriosis and 86 cases of control group. And we had excellent results. See, among these things, we can have upregulation of 125, 150, and 342, and downregulation of this 3613 and LET7B. So irrespective, what was very special with this non-invasive diagnostic tool was irrespective of the stage of the disease and whether the patient has got treatment or not, there was dysregulation of this miRNA. So this was used as a marker for early diagnosis. Then how the management part of it has changed. We know that management it includes medical, surgical, and ART for ART for infertility. And so this is a replication. Okay. So the current options for management of symptoms is we have been using, one is medical management, which can include hormonal or non-hormonal, or it can be a complementary alternate therapy in the form of heat application and breathing exercise. And they were given this, there's a lot of this analgesics and sedatives like cannabis to suppress the pain. And definitely we know that we have to alter our lifestyle modification and the diet which is low in inflammation. We have a special endo diet that can be followed, proper physiotherapy, mental health strategies, and yoga and exercise. So these are all the complementary therapies, and including Chinese herbal medicines, retinoic acid, all those things can be used. And coming to the medical management, the hormonal one is the combined oral contraceptive pill is the most number one, that is followed by GnRH releasing analogs, GnRH analogs, either antagonists or agonists. And again, non-inflammatory steroid anti-inflammatory drugs can be used, other analgesics and neuromodulators. Why neuromodulators? Because even if you treat the patient surgically, remove all the lesion, there is a nociceptive pathway which is already established. The pain pathway from the pelvis to the brain is established, and that is not suppressed by surgery. And probably these are the patients who need neuromodulators like gabapentin, etc. And the surgery means you have to have a complete removal of the endometriotic tissue and normalization of the anatomy. Not only this, following surgery, we need to suppress the lesion with medical management. That is because surgery is not going to hit at the etiology of endometriosis, which is totally different. Surgery is going to give you only pain relief through correction of this pelvic anatomy and removal of the endometriomas or the deep infiltrative lesion. So the mechanism of, let us see how the hormonal things act. So we have, as I said, combined oral contraceptive pills can hit at the LH and FSH can be suppressed. And then the progestins are selective progesterone receptor modulators. They can have a suppressed ovulation, direct effect upon the endometriotic tissue, and aromatase inhibitors. As I have explained already, there is increased expression of aromatase, which can be suppressed by letrozole or anastrozole, which can reduce the endogenous estrogen production. And this progesterone can act upon the estrogen receptors, steroidogenic enzymes, autophagic apoptosis, promote apoptosis, suppress cell proliferation, and reduce angiogenesis, neurogenesis. And this neuroangiogenesis can again be suppressed by the hormonal management using gabergolin, and immune response and inflammation. And of late, we have this GnRH antagonist, oral GnRH antagonist is coming into vogue. This analogs can suppress ovulation and ovulation at the higher level, suppress at the pituitary level, lead to hypoestrogenism. But it is not without complication. So this slide, I'm again repeating, it should be treated lifelong and surgery should be done only once and it should be a definitive surgery. So treatment we have already explained, and concept of medical management. Now, having said that medical management is ideal, how long you should treat the patient? Because again, you should never forget that it is a chronic disease which has to be lifelong management according to ASRM. So when you are going to use a drug for a longer time, we need to understand the safety and the tolerability of the drug. So the ideal way is to suppress estrogen, reduce retrograde spill, overcome progesterone resistant, anti-inflammation, aromatase inhibition, anti-angiogenic, and immune modulation. So based upon this, we have the drugs available. And again, with the problem with the medical management is failure or sometimes poor response. For example, not all patients will respond to progestin. 1/3 of them will not respond to progestin and they need to be shifted to GnRH antagonist. Again, it may give only a temporary relief. And again, many of the drugs cannot be used for a longer time and you can have undesirable side effects like vasomotor changes and non-compliance. And more often, it is an off-label drugs that are used because we have only few specific drugs which are available for definitive treatment. This is according to ESHRE. We can use NSAID, which can relieve only the pain and during menstrual period alone, COCs, progestin-only preparation, and GnRH agonist and antagonist, and SPRMs and aromatase inhibitors. And this chart gives you how it acts, mechanism of action, and what are the adverse effects and toxicity. So this was US FDA approval was given in 2019 slide in GnRH analogs and GnRH antagonist. So this was in US. Elegolis has been started into vogue right from the year 2014. And again, we have progestins, medroxyprogesterone, danazol, nita, and of course, we never use danazol nowadays because of the side effects. And European medical thing has approved triptorelin and dinegestor. So management depends upon the phenotype because the phenotype of this lesion is different, variable. The same drug may not be effective for each type of endometriosis. For example, peritoneal endometriosis, NSAID, COCs, and dineges will help. And endometriomas, probably the NSAID may not be of use, and COCs and progestins, all of us know that dineges to some patients, 60% of the patients, there can be reduction in the endometrioma volume. And in deep infiltrative lesion, none of this dineges, COCs, all those things are not going to help, but we need to have suppression, chronic severe suppression with the GnRH analogs. And of course, now we have the GnRH antagonist, which is supposed to be the ideal drug in suppressing the pain in DICE, and it can again be aromatase inhibitors can also be combined. So according to Chaperon and Versalini, they say oral contraceptives should, though it is it was considered as the first-line drug for treatment of endometriosis, they say it is progestin should be considered as a first line because we know that oral contraceptive pills contain some amount of estrogens which can only temporarily reduce the dysmenorrhea, but it will not, it will mask the development of underlying deep infiltrative dye. So that is as per Chaperon's wordings. And Versalini still goes further. He says that the estrogen content of the COCs can be a rescue factor. So when you start it on day 4 or day 3, whatever the regurgitated endometrial glands otherwise would have undergone spontaneous necrosis, because under the effect of estrogen, they start multiplying. So the rationale for using progesterone is found to be the ideal one. So we have moved on from combined oral contraceptive pill to the estrogen because estrogens, they have got suppresses the progestins that suppresses the estrogen levels. Progestins, they have immunomodulatory effect, anti-inflammatory effect, deserializes an atrophy of the endometriotic tissue, inhibits MMP and anti-angiogenic effect. So this is found to be an ideal one. So the ESHRE guideline, World Endometriosis Society, and all the learned societies are for using the newer progestin like dynages as the first line empirical medical management for endometriosis. So with the dynages, there will be reduction in the dysmenorrhea, reduction in premenstrual pain, and reduction in dyspareunia and diffuse pelvic pain. So the dose is between 2 and 4 milligram. But here again, I repeatedly tell that not all patients with endometriosis, they respond to dynagest. That is, and always I've been telling, by doing surgery, you are doing a surgical correction, correcting the anatomy. But the underlying factor that is causing the endometriosis development, like the transtubal spill or the coelomic metaplasia theory or lymphovascular or the inflammatory pathology, is not being taken care by the surgical management of endometriosis. So we need to put them on low dose post-operative suppressive therapy, at least for a period of minimum period of 2 to 3 years. So then why do we need newer drugs? So we have been talking about this COCs, progestins, and the newer progestin dynajet, but still we need to have newer drugs. That is a change in the paradigm in management of medical management. So we have to understand that 1/3 of the patients are non-respondent to COCs and progestin, and GnRH agonist and antagonist can be used. But again, the GnRH agonist, as it's very effective in treating the symptoms. If you put the patient on 3 doses, the patients are very comfortable. They say, doctor, I am free of the disease, but free of the pain. But they will again say that because of the extreme suppression of E2 to less than 20 picogram, they have unpredictable side effects like increased vasomotor changes and dyspareunia and all those things. Side effects are becoming more because this, and again, once you can give GnRH agonist in the depot form only, and it is in a fixed dose. So these are all some of the disadvantages with GnRH agonist. So we need some drug which can very well suppress the estrogen level without causing much of vasomotor changes, and it should be dose adjustable. So in that place, we have the GnRH antagonist. So sperms are also not a viable option because it is off-label use. So the newer strategies are to reduce estrogen active sensitivity. We can use GnRH antagonists, aromatase inhibitors, and selective estrogen receptor modulators. To reduce the progesterone resistance, sperms can be used, and reduce inflammation and pain. They are to the extent of using monoclonal antibodies, prostaglandin receptor antagonists, and reduce peritoneal inflammation and invasion. We can use dopamine agonists can be used because of the increased VEGF and neurogenesis can be suppressed. Also, we can have MMP inhibitors that can also help in suppressing this peritoneal invasion. So the gap in the current treatment option is, as progesterone is resistant in 1/3 or non-responders, and this GnRH agonist is associated with initial flare-up, and then it can have other side effects and reduction in the bone mineral density, unpredictable reversibility of the treatment. Once when you give in the depot form, it cannot be reversed for certain time, and then inability to titrate the E2 levels. Once when you give the depot, the E2 level goes less than 20 picograms, and there is disturbed cyclicity. Patient usually goes into a state of amenorrhea. And there are also, we know that it has long-term safety issues. So what is the ideal drug? We need to maintain the estrogen threshold that is between 20 and 40 so that there are no vasomotor changes. At the same time, the disease will not grow up. So elagolix has been developed from 2004, 2010, phase 2 trial for uterine fibroids, and 2018, this is why the US FDA has approved this again for endometriosis, and in 2020, uterine fibroids, US FDA has approved for uterine fibroids. It is only in 2024, DCGI has approved elagolix for treatment of endometriosis in India. So there are certain differences between the modality of action of GnRH agonist versus antagonist. So the antagonist can block the receptors immediately, it can suppress, and then, as I said, the effect is immediate and the threshold level is maintained. But whereas in GnRH agonist, it binds the receptors, it depletes the receptors, and then you cannot have, it is in the phase of amenorrhea. But with antagonists, the patient still can have menstruation. So no flare effect, estrogen suppression is within few hours with no initial flare, and then it maintains the estradiol level, and it is dose adjustable with 150 milligram either or 200 milligram can be given. And the most important thing is non-menstrual associated pelvic pain is being handled with GnRH antagonist excellently. Like Dynages, it can reduce the dysmenorrhea, and dysuria, but the non-menstrual pelvic pain such as dyspareunia and then diffuse abdominal pain can all be handled with GnRH antagonist, and it promotes the quality of the life. It reduces the need for rescue analgesics and also the opioid derivatives for pain suppression. So this can be how long it can be used. If the low dose, it can be used for a period of 24 months, and with the high dose of elagolix, we have to use it only for 6 months. See, how should you use elagolix 150 milligram for a patient with this study? As I said, it was done by Hughes Taylor. In the 18 to 49-year-old women are taken, and they can be either moderate to severe disease. So in a moderate disease, the patient can be put on elagolix 150 milligram, and severe disease elagolix 200 milligram BID dose can be given. So this was the result of Elaris EM1 trial. And here they have used placebo, elagolix 150 milligram, and elagolix 200 milligram BD. And this study was done for a period of 6 months, and they found out that was a reduction in the dysmenorrhea, and non-menstrual pain, pelvic pain is also diminished with the elagolix. So again, the Elaris EM2 trial, this was parallelly done. That trial was done in US, and this was done in apart from US, and they found out that the same result, that there was a reduction in the dysmenorrhea level as well as non-menstrual pelvic pain at the end of 6 months. And the extension trial was again done. This was done for a period of 1 year, where dysmenorrhea, non-menstrual pelvic pain, and dyspareunia were compared. And here again, this dyspareunia was very much depressed, reduced with elagolix 200 milligram BID. But all the others, maybe with comparing elagolix 150 milligram to 200 milligram, here at the end of 12 months, almost the non-menstrual pain is equivalent to 150 milligram or 200 milligram, but dyspareunia is reduced to extent with 200 milligram BD dose. So total overall, there is a reduction in the dyspareunia, dysmenorrhea, non-menstrual pelvic pain. Sustained decrease is seen at the end of 12 months to 24 months. So the action is very quick. This is tolerability is good. And the one important thing is the menstrual cycles are not altered when you are using low dose. Okay, and at the same time, the resumption of periods after stopping the drug is very fast, and dose-dependent modulation of estradiol levels are available. If you are going to use 150 milligram, it can be given for 8 years, and the level of E2 is maintained between 20 and 40. That is the optimal threshold level is maintained. And if you are going to use a higher dose, it is very much depressed. So here, the administration is without any coexisting condition. 150 milligram, 24 months, it can be given with severe dyspareunia, 200 milligram twice daily. With average hepatic, we have to be very careful when the patient has got an hepatic or a renal involvement, and the dose can be reduced if the patient has got a liver impairment. See, in this is again 5 options how you can choose the drug. If the pain is very severe, you can start with 200 milligram BD for 6 months, but you see there is greater bone loss. But if the pain is moderate, then there is a good improvement and there is a minimal BMD reduction. Or for if there is going to be a severe one, maybe for the initial 3 months, you can start with 200 milligrams so that it will reduce, it will have a very good improvement, and we can maintain it with 150 milligram OD for 24 months. So that means there is minimal bone loss. So according to the requirement of the patient, we can adjust, start with a higher dose and end with a lower dose, or start with the lower dose itself. And dydrogesterone is another drug which I wanted to mention, because in patients who are in need of conception at the same time, if they have pain, Dydrogesterone is an excellent drug it is an anti-inflammatory drug by itself, and you have to give it first the dose of 10 milligram BID starting from day 5 to day 25. The drug being a retroprogesterone, it will not inhibit ovulation, and the patient can have both reduction in the patient pain as well as conception. So it will have a similar effect to DMPA, norethistérone, etc. So this was an Arcadia trial study which says that continuous regimes of dydrogesterone are prolonged cyclical on continuous regimes are useful in reduction of the chronic pelvic pain, and cyclical regime will helpful in conception also. LNG-IUS is also an initial phase. We can start with the GnRH analogs or antagonists, and in patients with associated adenomyosis and AUB, LNG-IUS can be inserted. And again, still I find that Depo-Provera is an excellent drug which can be used for a shorter period, because we know that this drug also causes BMD reduction, and it has been in comparable result to OCP, GnRH analogs, danazol, and danazol. So this can also be very safely used. Aromatase inhibitors can be used as a second-line drug, especially when there is associated adenomyosis, where you want the adenomyosis volume to reduce prior to infertility management. Anti-angiogenic drugs like gabapentin can be used. Tumor necrosis alpha inhibitors, any of the tumor necrosis alpha inhibitors can be used when the patient has got severe pain. Immune modulators they are loxorubin that can suppress the NK cell activity, which is elevated in endometriosis. So this is one reason NK cell activity elevation is the cause for infertility. So we can give this, and interferons and tumor necrosis also. All these drugs are all in the experimental stage, and they are helpful in the early stage, because only in the early stage of endometriosis, this all pro-inflammatory changes are marked. Interferons can also be used, and as I have mentioned early, correction of gut microbiota by giving metronidazole or proper antibiotics that can also help to revert endometriosis. So complementary therapy, we have already discussed. Chinese herbal medicines can also be used, but we have to tell the patient that it is only an off-label use. Resveratrol, I have already mentioned. Retinoic acid, and probably the future direction is we need to treat targeted gene, and genovoid association will help us to find that which is the gene that is affected in endometriosis, and genetic bioengineering is possible so that we can correct endometriosis. And of course, artificial intelligence is of much use, because if you feed it, if you can tell that what are the symptoms, what are the imaging evidences, and what is the previous treatment the patient has taken, it can give you the plan, what should be the drug the patient really needs and how it should be proceeded. So again, for the pain management, it can be both surgery and medical. I am not getting into much of this surgical management. And again, now the most important paradigm shift is fertility preservation versus donor oocyte. Previously, we have had in my practice, we used to do 2 surgeries or 3 surgeries, and ultimately when the patient wants conception, we did not get any oocyte through ART, and the patient has to depend upon donor oocyte. But now, because of the excellent procedures like oocyte cryopreservation, embryo preservation, or ovarian tissue preservation, these things can be suggested for fertility preservation. So this is again a very important slide, because when you want to treat pregnancy pain alone in peritoneal endometriosis, it can be either OCP or NITA or Dynagas, failing which we can give GnRH antagonists with the add-back therapy. So again, probably this elagolix molecule, they are going to come back with the add-back therapy. And there are 2 other antagonists like the elagolix and the linsagolix, which already they have an add-back therapy combined with them. That is the low-dose ethinyl estradiol with norethindrone, which can be used for quite a long time. Again, if there is an ovarian endometrioma, if the patient has got only pain, lesser than 3 centimeters, go for medical management. Greater than 3 centimeters, still medical management will be the first line, failing which you can go for surgery. And in the surgery, post-surgical follow-up with some form of suppressive therapy is needed. And for deep infiltrative endometriosis, it will be the best will be the GnRH antagonist, which with a higher dose, 200 milligram twice daily can be used, or lesions that are greater than 3 centimeters. Probably an expert team of surgical consultants can go ahead with the surgical excision and follow them with the GnRH agonist. Suppressive therapy has to be maintained. Then in patients who are infertility, we have to balance whether they need surgery or ART. In peritoneal endometriosis, ART, I think the ideal one will be correction of this endometriotic lesion, because most of them are in the early stage, and when we put in the scope thinking that it is an unexplained infertility, to our surprise, we see the peritoneal endometriosis where it has to undergo complete excision, or even butterfly excision is possible now, or we can go for ART. In ovarian endometrioma, two things are available. Depending upon the reserve of the patient, you can either, if it in a low reserve, we can go for ART. With a high reserve, probably we can go for surgical management. If soon after surgical management, patient has to be started upon ovulation induction. During surgery for ovarian endometrioma or endometriosis, we have what is called as an endometriosis fertility index scoring. And based upon the scoring, if the score is high, spontaneous conception rate is quite good. And if the score is low, probably it is the time at which we have to shift the patient to straight away to ART. Then deep infiltrative endometriosis associated with infertility, maybe surgery or ART. And there are certain evidence to say that properly done surgical management of DIE can improve fertility up to 50 to 60%. Otherwise, you can give antagonist and then suppress the lesion and then go away straight away for ART. So to finally, the endo life starts with diagnosis, and this was probably the previous yesteryears. Immediate first surgery, post-operative medical treatment, repetitive surgeries, and finally ART, by which time the patient will be devoid of oocyte. And the endometriosis, non-surgical diagnosis, we have to put them on long-term medical suppressive therapy, and desire to become pregnancy, probably we can have a single complete surgery, then ART and long-term medical management. But currently, what chaperone says is non-surgical diagnosis should be the first one. Long-term medical suppression therapy. If they need infertility, we can go for ART and then maintain on long-term medical therapy. So there is no need for surgery. But still, again, following this long-term medical therapy, probably if the patient is not getting the symptoms are not getting relieved, a single appropriate definitive surgery should be done at the end of the reproductive life of the woman. So the take-home message is endometriosis needs a lifelong treatment. Medical management should be the priority. Surgery should be done only once. Currently available medical managements can be used for a short term, and it acts by suppressing the hormones. Treatment should address both pain and infertility, and it should be based on the phenotype. It is time to promote research, encourage innovation in treatment options, as well as in diagnosis, and improve women's access to quality care. Efficacy and safety in real-world population need to be evaluated, and comparative study with all the available medical therapy has to be, the research should be done on that. And it needs being a chronic inflammatory disease, it needs supportive and continuous medical therapy. Once again, I tell you, follow up these patients lifelong, because they are at high risk of developing coronary artery disease and cerebrovascular diseases. So routinely used drugs, they can interfere with the infertility, and we have to choose which patient, which is needed, and we have newer molecules, and genetic engineering can help in suppressing the symptoms and reducing the disorder. So medical management should replace surgical management prior to ART in the event of recurrence. So I thank you for the opportunity given to me.
Yeah. Madam, thank you so much, madam. You have spoken for almost for an hour, more than an hour, in fact. So I think now I am really right when I said introduced you as an encyclopedia of endometriosis. Of course, this one lecture is going to be enough to really understand endometriosis. People can really look back into this lecture and know the current updates on endometriosis. It was really, really wonderful, and it's worth a treasure to have this lecture with everyone. I think you can use it as a reference guide. So very beautifully you have highlighted on various aspects, madam, right from diagnosis, like how the biomarkers, though, there are lots of only studies are still being on these biomarkers, and we do not have categorically one single biomarker to say that, okay, whether this is going to be an endometriosis or it is going to be any other disease with peritoneal inflammations. And still lots of studies are happening, but we are yet to wait for the results. And of course, the mRNA, of course, you have done phenomenal work in mRNA. It is only that now we have to accept for the acceptance by the major society so that it can be implemented in our routine practice also. So
already Mala Professor Deschamps from Germany, he has done a work on this, and he has replicated the same microRNAs and CAR test he has developed from the saliva. So
yeah.
I am working with the IIT people of Chennai to bring about the same CAR test, like a sort of pregnancy test. We'll be soon having just put in the serum of the patient. If it shows 2 lines, probably the patient is suffering from endometriosis.
Endometriosis, yeah, it is available, madam. The salivary biomarker.
Yeah, salivary thing is available. It is around 8,000 rupees cost abroad. Probably if we are able to get it in India, it will be less than 1,000 rupees.
Yeah, so Dr. Phillips also once, I think, highlighted on this particular topic, madam, of biomarkers. It was a wonderful lecture by him as well. And of course, very right. I mean, how about this endometrial biomarkers, madam? Do you have anything like, I think there are some research work is also going on that field.
Yeah, I'll tell you, there are not only peripheral circulating biomarkers, but you have endometrial biomarkers.
Yeah.
That is, these endometriosis patients have severe pain. Okay, that is, you have small sensory C nerve fibers in the endometrium of endometriotic patients. It is found to be 14 times higher than in a non-endometriotic patient. This work has been done by Professor Tushar Kar, our previous ICOG chairperson. So taking a simple biopsy and then subjecting the endometrium to IHC with this pan PGP staining, that can also pick up, but that's a minimal invasive procedure. Apart from that, there is also another biomarker. They are able to pick up the circulating free endometrial cells in the patients with endometriosis. So that is also, so there are so many biomarkers.
Which are,
each one has got its own merits and demerits.
Yes, many are in the pipeline, I suppose, madam, and they have to just wait for the time for approval, and then we can.
There are a few questions.
Lots of madam, lots of compliments, madam, for your talk. And I think there is someone who has asked for poor patient compliance associated with Dynogest and Elagolix, can we go for a monthly GnRH agonist in these patients? And if we are using GnRH agonist, what to do for the bone mineral loss prevention?
Yes. See, patient with Dynogest, that is poor compliance. That is I have been repeatedly telling 1/3 of the patient, they don't respond to Dynogest. So they need some form of GnRH agonist or antagonist. When comparing to agonist versus antagonist, I think agonists are better because it is dose adjustable and it can be used for 2 years at a lower dose with a minimal amount of add-back therapy. But if you are going to use GnRH agonist, it cannot be used beyond 6 months. And at the they usually in the textbook description is after giving 3 doses, you start the patient on add-back therapy. Add-back therapy should be either it could be a low-dose estrogen or a progesterone, or it could be a COC. And sometimes the bone mineral density has to be managed with this alendronates also. You can give alendronates, supplement with vitamin D and calcium. So, but by and large, it is always safer not to exceed 6 cycles of GnRH agonist. But I've seen people, you just give 1 dose or 1 or 2 doses of GnRH agonist. They are quite comfortable for a period of 6 months. I think you would have also experienced. When they come back, give them 1 or 2 shots. They will see, like that we can manage. And
so regarding scar endometriosis, which is better, whether it is Elagolix or Dynogest, someone wants to know, ma'am.
See, scar endometriosis have to be managed only surgically.
Yes, you have to excise the scar.
Excise the lesion, wide excision is the only treatment. Maybe temporarily you can use Dynogest or Elagolix, but it is not going to. Maybe probably for recurrence, a small recurrence you can use But sometimes what happens is if the patient is already put on these drugs, when you do the excision, we won't be able to find out the lesion at all. It will all be fibrosed.
Yes, exactly. Yeah,
Okay.
very true. So surgical management is the right thing for scar endometriosis. And yeah, so
Cost of elagolix, I
yes,
think it is
cost of
75 to 90 rupees depending upon the
I think
spread.
in a month it will come to like 2,500 to 3,000 for a
Yeah.
So approximately it comes to that. Okay, so excellent, ma'am. Like now we have beautifully highlighted about the oral contraceptive pills. Always I had that in my thought, like how this is an estrogen progressive disease. Then why are we giving estrogen at all?
Yes.
You know, like so, and if you have to give estrogen, progesterone, it has to be a continuous and not sequential and all those things. But then now the Diagnostic has come up. I think it is better we stop using
Stop using. And now it has come only second line of drug.
Yeah,
OCP
exactly.
is no longer a first line of drug.
Yes, as you said, the reflex menstrual fluid, which is undergoing a necrosis or apoptosis, can be stimulated by this estrogen, is what we are giving. So we are not doing any good to her. And when it comes to diagnosis, again, you have also beautifully highlighted how ultrasound, the TVS ultrasound and the MRI are also very, very good. And of course, the TVS is really done well. I think that is the best thing to pick up even a deep infiltrating endometriosis. Now, the MRI pictures are also very good, ma'am. And how they do the MRI, they have to put some gel inside the vagina and then take the pictures, and all those things are important, because when you do a laparoscopy, the exact picture of your MRI and your laparoscopic pictures will be correlated. Yeah. So in that way, they are really advancing very well with even imaging modalities.
And then one more thing, in MRI, they calculate the distance between the posterior vaginal faucet, vaginal faucet to anterior margin of the anal verge. It is found to be shorter in patients even with early endometriosis. That is again a non-invasive diagnosis, MRI diagnosis for endometriosis.
Yeah, fantastic, madam. So, and again, you also highlighted how about the laparoscopy. So earlier we are saying the gold standard is laparoscopy. Now Esri has come forward and said that you're doing laparoscopy, do it only when you are ready for an operative procedure. Don't just put a laparoscope, say you're going to diagnose and come out and take a biopsy. That is not mandatory. Only we have very clear-cut evidence that it is an endometriosis. Put in a scope and then make sure that you excise. Otherwise, do not put a scope. So that is very clear. And when it comes
to artificial intelligence is going to be the way forward.
Good. Yes, yes. That is also very thing, because we know like where exactly the lesions is. And sometimes when you're in a real dilemma, if you feed in questions, you are able to get an answer. And when it comes to, again, management, of course, you have beautifully highlighted, madam, the medical part you have highlighted. And of course, that 30% of progesterone resistance is very, very important, which you kept on saying. That is very important, because there will be a group of individuals who are resistant to progesterone, and that those are the ones who would respond to the GnRH antagonist, anagonics. So when to use GnRH analogs is what we need to understand. And I think in due course of time, maybe first it will be like progestins, Dynogest, and then next second line will be the allogolics. And most of these endometriosis, when they have pain, they are not responding to any of these medical managements. This is mainly because of the fibrosis. You have also highlighted, madam, in such cases, you have to only go for surgery. So that is only because of the fibrosis. These pharmaceutical agents are not able to penetrate into the fibrous tissues, and that is the reason they do not work. And wherein we have to do a surgery, and post surgery, you have 100%. You have highlighted each and every time that you have to cover them up with the continuous therapy, maintenance therapy of GnRH agonist or antagonist, whichever are the progestins. I think these are the few things. You have summarized everything very well, ma'am. Not left a bit of it. And of course, the aromatase inhibitors are also very much because of the aromatase enzyme deficiency, and how the aromatase inhibitors are also playing a very major role in the management of endometriosis also have been highlighted. And of course, the probiotics role also have been highlighted. Now the probiotics having a role everywhere. In fact, it is becoming something like our vitamin D now. So it is good. And of course it is good. It has got brain. Okay, madam. So I think we have taken almost more than 1.5 hours of your time for this, 1 hour and 15 minutes. So it has been a very, very wonderful session. And then I just one point I want to know, ma'am. one point regarding anabolics and add-back therapy of norethistierone. So, how much of norethistierone and when do you start when you put the patient on allogolics, ma'am?
Norethistierone is 5 milligram. Now we don't have an combined therapy. Soon, I think Olympic is going to come out with a combination therapy. And they had already planned for relagolics with combination therapy that is not DCGI approved. So we can start it. If you are going to start with 200 milligram BID dose, we have to start an norethistierone much earlier. If it is going to be 150 milligram OD only, then you need not start.
Yeah, so I am
maintain the threshold level of estrogen.
Estrogen 20 to 40 milligram. I am very happy with allogolics, madam, because most of my patients after surgery, I put them off on allogolics and they are very, very comfortable. Absolutely no complaint. So because after surgery, we want the patient to not, complain anything at all. So these patients, when they are on a maintenance therapy, they are doing wonders.
See, even I feel after post-hysterectomy for endometriosis, put these patients for some time on allogolics or simple DMPA.
So
DMPA can also help.
Yeah, postmenopausal women, also again, if after hysterectomy, if you are, wanting to give her some kind of a hormonal replacement therapy, so what are the precautions that you really take? Like if it is an endometriotic patient, hysterectomy done, and she wants a hormonal replacement therapy, what would be the ideal drug?
That is, what is the drug? No, that is we don't give estrogens, we don't give progestins, but we can give the
tamoxifen.
I tell you, that is mild estrogenic, mild progesterogenic, mild androgenic action is there with tibolone. So tibolone will be an ideal drug. So tibolone can be started 1 month after the surgery.
Yeah. Okay, madam.
Or simple, sometimes you can give a combination of low dose estrogen and progesterone combination.
Okay.
Very low dose, 20 mics of estrogen with low probably that also can be.
Femostrone is available.
Yeah, femostrone will be good. Femostrone will be good, definitely.
So I think we can give 2 for these patients. Yes. So someone has asked, like, how many days you will advise allogolics after surgery, and what is the duration and dosage of allogolics post surgery?
150 milligram per day for at least minimum period of 6 months.
6 months, yes, correct. Yeah. So anything else? So Meena, or anything else you want to ask, madam? Because I think this is a very, very extensive, this is the whole idea, madam. When you take a topic, how to, you go in depth of the particular topic and then cover all the aspects. Topics, it is not. So especially when someone is good in that particular field, you have to, you have to learn. So, I think someone, I have to please mute yourself. Dr. Abhirami, please mute yourself. So I think with this, I think we come to the end of the session. Madam, on behalf of Oxy, I'd like to extend my heartfelt thanks to you for spending your valuable time. And I know how much of research work you've been literally doing in this particular specialty. And I think we listening to this have been really benefiting out of all your hard work. Thanks a ton for providing us with your valuable inputs, madam. So we will see you again in another some other meeting, madam, to know more about a different aspect of endometriosis, because understand this endometriosis in different compartments. You have to understand at the basic molecular level to understand the disease and the management. So with that concept, I would like to also thank our president of Oxy, Professor Sampath Kumari, madam, for giving me this wonderful opportunity to keep organizing this webinar on endometriosis, and also thanks to Dr. Meena also for joining us and taking this webinar forward. So
thank you, Mala ma'am, for the excellent coordination. Thank you, Ramani Devi ma'am, and thank you, Sampath ma'am, Meenakshi, Sri Priya, Shield Healthcare, for having given the platform, and all the delegates. This will be live on YouTube, so we can have it cherished again and again. Thank you, madam.
Yeah, so thank you, madam.
Thank you, ma. Good night.
Good night, madam.
Good night, madam.
Good night. Bye.
Thanks, Meena. Good night. Thank you, everyone. Bye.
Thank you, madam. We'll meet tomorrow, madam.
Yeah. We'll see you in Chengalpattu Medical College.
Yes.
Legal workshop.
Yes.